Hello and welcome to the Patient Educators Update, where we talk about patient education in a clinical environment. I'm Chuck Jones with Synergy Broadcast, and as always, I want to welcome our guest, Fran London. Hi, Fran.
Hi, Chuck.
Fran is the Patient Education Specialist at Phoenix Children's Hospital in Phoenix, Arizona, and she is also the author of the book, No Time to Teach, which we use as a source of many of our topics on the Patient Educators Update. That Fran's book is available wherever books are sold, and it was voted the 2010 Book of the Year by the American Journal of Nursing. So Fran, we're not gonna pull a topic from the book, even though you do address this in your book. We're gonna pull it from an article that came out July the 26th. It was published on the blog of the American Association of Family Physicians, and it talks about patient literacy, and the heading is Understanding Patients' Literacy Level is a Crucial Step in Care, and I think you would certainly agree with that. I want to share with you some of the statistics that were quoted in the article because they're kind of shocking. For starters, fewer than half of U.S. patients have the necessary skills to read and follow drug label instructions, respond to insurance forms, provide a patient history, or communicate effectively with a physician. And this is from the National Institutes of Health. They also said that this problem is estimated to cost $236 billion a year in the healthcare industry. And it's not a new problem. 20 years ago, the University of Arizona did a study and found that low levels of health literacy were more than 4 times higher. This was Medicare patients. Low health literacy was 4 times higher with them than it was with those who were health literate. And in 1993, this survey found that 22% of Americans were unable to read a medicine bottle. Those are fairly shocking numbers to me. In this article, she talks about steps that need to be taken to make sure that we're determining if our patients are literate and what their level of health literacy is and how we should go best do it. And one of the things she talks about is that there should be a form or a checkbox on the patient history form that determines how far did you go in school. And then, that way you know what their literacy level is. But in her article, she mentions the fact that only 30% of people with a bachelor's degree are considered proficient in understanding health literacy. So that doesn't sound like a good measurement to me of health literacy. And I already see this on every patient history form I've ever filled out. It always asked, are you a college graduate or not? How far did you go? It's already there, and I don't think it does any good. Let me ask you to comment a little bit on what you see, how big is the problem of health literacy with patients, and then talk about the best way to determine literacy level.
Well, it is a huge problem. And you can see the results because compliance just isn't there. They don't understand what's going on. Mm-hmm. They don't know how to treat themselves. They don't know what the problems are. And they just get into trouble. So it costs money to support this.
Yeah.
The assessment of health literacy is getting a lot more attention, and there's been a lot more research into how to best do it. Now the current thinking is if you see someone that you have a concern about, it's best to ask something like, did you have trouble filling out the forms? Mm-hmm. Because there's always forms involved, and it's a non-threatening question because if they do have trouble reading, they will have trouble filling out the forms, and that will help you assess a little bit more. Personally, I prefer to not address health literacy as a separate issue because I think if you do regular assessment before you do any teaching anyway, you're going to find out that they don't understand. And that's really just by asking them, what do you know about this illness, and listening to how they answer you, what words they choose to use, how specific they are, how general they are, And that can give you a hint as to whether to assess more fully.
Okay. So you are actually saying don't focus so much on the health part of it in the beginning or the health literacy part, just have a general conversation, and as you ask them about their situation, you will get clues from them that'll help you determine what their level of understanding is.
Now, people with very poor health literacy and poor reading skills have spent a lifetime trying to cover it up. So they will throw things at you that might make you think, oh no, they really can read, they're just not reading. Like, I don't have my glasses, can you tell me what that says?
Yeah.
So listen for those cues too. But what you want to know is if they're capable of following through on what the treatment plan is.
Yeah, I know one of you, we've talked about health literacy in at least two other episodes, episode 5 and episode 13. Episode 5 just talked about health literacy, and episode 13 was how to evaluate patient understanding. And I seem to remember that one of your questions always was how to find out how the patient normally learns. And you ask them, how do you normally learn about something like this? And then you'll get a clue from them about that.
Yeah, because if you ask the last time you wanted to learn something, how did you go about it? And they never say that they read about it, but they say things like they asked somebody to show them, or that they watched a video, or that will give you cues that they don't learn from reading.
Yeah.
Yeah.
And there was a section in the article where she talked about, the author of the article talked about making sure that you provide patients with the appropriate reading material in advance of the appointment so they can read it while they're waiting, which is fine, but if they're not readers, it doesn't help much.
Right. And you haven't yet done the assessment, so you don't even know if that content is the content that's appropriate for that patient at that time.
Yeah, so under the heading, I don't have time to teach, this becomes an obstacle to that because you're doing a bunch of things ahead of time when you don't even know if it's appropriate or not.
And you might turn them off,
Yeah.
and you might get them more defensive. If you're handing them things to read and they can't read, they're going to come in already defensive.
Yeah. What are your thoughts on the education level that something should be written at? She makes a comment that health education material should be written at the 4th or 5th grade level, but is often at the 8th grade level. I will tell you, I got a handout from a pharmacy the other day that was written at the PhD level.
Yeah. It's something that's been very inconsistent, and we do tend to give things at a much higher level than necessary or appropriate. My finding, basically, the simpler it's written, the better, because the more likely it is to be understood. And there's no reason not to write it simply, because people are not offended if it's got the content that they're looking for and they understand it when they read it. They just don't notice that it's at a simple level if you're including all the content that's necessary. And it can be done. The reading level is an issue in that the way they calculate how high a reading level it is, it's the length of the sentences are part of the calculation, and the number of syllables in a word. So if you have a lot of words with many syllables, it will raise the reading level of the material. And if you have diabetes, you've got 4 syllables right there, and that's raising the level. However, when you think about it, people with diabetes recognize the word diabetes, so it doesn't actually functionally raise the reading level of what they're reading, because they know what that is because they have it.
Yeah, I see what you're saying. And of course, diabetes would be an easy one to pick on, but if you have another disease that there's not a common name for, that is strictly jargon, that's a whole nother issue, isn't it? Because jargon's a big problem.
Jargon's a big problem, but a lot of the terms that we use can be said in simple terms. We just don't think to do that.
Yeah, I know. I got over being stupid about this stuff a long time ago, and so if my doctor says something that I don't get, I said, can you explain that in terms that I can understand? And I'm not embarrassed about that. Doesn't bother me a bit because I know that there's stuff I don't know. But that's not always the case with patients, is it?
And if you come to the appointment thinking that you're supposed to understand the doctor or that you're not supposed to question, then you walk out not understanding what you were supposed to do and what's wrong with you.
Yeah, and she brings up a couple of points in here that she says patients don't often know what they should ask. I would almost submit that the majority of patients don't have a clue what to ask. Unless they've studied what they think is going on with them, they won't know what to ask. They're expecting the doctor to give them everything. Would you agree with that or no?
Yes, that's often the case, especially in people who see doctors as authority figures. And when it's a new diagnosis that they're thrown into, they wouldn't know what to ask because there's that first initial emotional shock and then the getting used to the idea that something really bad is going on. So you don't know what questions to ask at that point. All you want to know is, why me?
Yeah.
So, and it takes a while to think about what questions you do have. And a lot of them relate to how do you function in life? What do I eat? What do I not eat? What can I do? Those sorts of things. And those don't really come up until you go home and you have to eat your next meal or have to decide whether or not you can be active.
Yeah, and I would, I would say that there have been quite a few doctor's appointments for either me, my wife, mother, or my kids that those topics never came up. They were never asked. So that some critical information could be gained at that point if those kinds of lifestyle questions were asked. Something else that she addresses in the article that she talks about dealing with residents and students, because she said they're not given training on this in medical school. And she says that if you work with residents and students, listen to how they speak to patients and challenge them to speak at a level patients understand, and then ask the patient, do you understand what is being said? Well, that's one of your big no-nos.
That's one of my big no-nos, because people are going to respond by saying, yes, of course I understand.
Yeah.
You really have to have them teach it back to you in their own words so that you know how much they understand.
Yeah, and go ahead.
Well, I just want to put in a plug for an app that my hospital has that's very appropriate to this. It just came out. It's called Simply Sayin', and it's for residents specifically and medical students. And it because I work at a children's hospital, an app that helps them know what terms to use when they're talking about a surgery or they're talking about treatment that could be frightening, what words to use that are accurate, that prepare the child appropriately, but do not scare children.
Okay.
So it's really quite a fun app. It's free for everybody. It's called Simply Sayin', S-A-Y-I-N.
Now, is it Android and
yes.
Okay.
Yes, it's iPhone, iPad, and Android.
Okay, wonderful.
And English and Spanish.
Oh, okay. Well, that's cool. I didn't know about that app, so that's excellent. Now, I'm going to give the author credit because right after she uses your no-no phrase, do you understand what is being said, she addresses teachback. And
she just doesn't quite know how to do it.
Yeah. She talks about teaching back being vitally important, not only for students and residents, but for all healthcare professionals. And then she has some other statistics. 40% of information patients receive is forgotten soon after the appointment, and roughly half of what they do remember is inaccurate. The brief time it takes to ask a patient to repeat the instructions you have to give them can make a huge difference in compliance and outcomes. And I would submit that teachback is critical just for reinforcing to get it implanted in the patient's brain, and you should do it more than once.
In different ways.
Yeah.
You do it in different ways. Because some of it is like, what did I just say? And then you could ask, well, what are you going to do when you get home? Which is kind of applying that information.
Yeah, yeah, because you really can't expect once, because I forget stuff from 2 minutes ago, so I can relate. Why don't you talk a little bit about non-readers, and that's people who can read and choose not to versus people who can't, and how best to handle that situation.
Well, the first step is to identify them, which can happen when you ask them, how do you learn? What was the way you used last time you tried to learn something? And if they say they had to ask somebody to show them, or they used a video, or they watched it on TV, that'll give you a hint about how they learn. And then you really should have resources on hand that you can use to address those issues. Obviously, conversation works with everybody who is conversational, and reinforced with video is always a good idea, where you can show them the video, and before you show it to them, tell them what it is you want them to notice about it, and then after the video, ask them what they saw and ask them to teach it back to you, so that you get that information through to them in a way that they can understand and help reinforce it so that they can remember it. Because people who don't read or can't read use their memory quite a bit to function.
Now, you mentioned video. She doesn't address video at all. Everything in her article appears to be about the written word. But you talk about learning styles in your book, and we've addressed it several times on episodes. Why don't you address learning styles just a little bit?
People latch on to things differently. And I think the most recent research talks about how it's not so much that some people are more visual and some people are more auditory, although that's true. Everybody learns through all the ways that you get the information in. So it's really helpful to give the same information in lots of different ways so that those brain connections are made. So that the brain connection between what you hear and what you see and what you've read all kind of reinforce one another, so the information is connected to what you know already, and you're more likely to remember it and be able to do it.
Yeah, and I would, on the topic of video, especially in a hospital, I would encourage when video is being used, that patients are encouraged to watch videos more than once. And specifically for that reason, think about watching a movie at home or the movie theater. The first time you see the movie, you have certain impressions about it. But then if you watch it again a second or a third time, there's always something in it that you didn't see the first time. And so watching it repeatedly not only helps with the connectors that you talked about, but also will either bring to light things that you didn't see the first time, or the little light on in your head will go off when you see, like, oh, there's an aha moment that you and I might refer to, but somebody else will go, oh, now I get it.
Exactly.
And which refers to the connectors that you're talking about. And it's all reinforcement. And so, and the good thing about the patient education videos that are being produced today is they're short. They are, just takes a couple of minutes to watch. And if they can be watched by the patient by themselves, and then when different family members are there so that they get the information, the patient sees it a second, third, fourth, fifth time, it all helps to kind of reinforce it, make the connections that you're talking about, and present things in different ways that all help it be retained a little bit.
Yeah, that is the best use of video.
Okay, one last question. She makes an interesting comment about numbers and measurements. That's not something that we've talked about, but this would especially be true for patients that are having to take medications or even measure specific doses of medications for different reasons, like diabetics, different doses of insulin, or maybe if you're taking a liquid medicine, there's a different dose. Things are in milliliters. Well, how many Americans know what a milliliter is? And so if a person is having trouble with reading in general or comprehension in general, excuse me, how do you deal with numbers and measurements when that's a challenge?
We, first of all, should not make assumptions that they understand numbers and measurements.
Yeah.
So again, you have to assess as to where they are with that.
Okay, so what you're saying, if they have a bachelor's degree, we know that only 30% of them are proficient, but if they were an English or an art major, they may not get numbers at all. No offense to English and art majors.
I'm not making those assumptions.
Yeah.
But yes, you don't know. You can't assume.
Yeah.
And you don't know if, when they went to school, they understood it, and now years later, they've had some head trauma and they're not understanding it at all. So again, it's hard to make those assumptions.
Sure.
You have to assess and figure out, and a lot with measuring medications, you could do the show me, the teach back of, demonstrate, can you draw up that right amount of medication? And then you'll know whether or not they're capable of doing it.
Yeah.
A lot of the research now looks at, do people understand the risks of doing something or not doing something? And risks are numbers. People are a lot more afraid of some things that are very rare to occur than they are of things that are much more likely to occur, like a plane crash versus a car crash. They're afraid of planes, but car crashes are far more likely to happen.
Yeah, and more deadly. Yeah, sure.
Those numbers are hard to understand and absorb and apply appropriately. So we really have to watch our conversations and how much we throw these things around, because healthcare providers live in a world that's very different from the average person. We have a different vocabulary. We have a different way of looking at things. We have a different way of deciding what treatments are appropriate. Patients may want what's most comfortable as opposed to what's most likely to succeed at giving them another 3 weeks of life.
Yeah.
You have to find out what their priorities are and what their interests are.
Yeah, and there are things that you can do that would help them, like with liquid measurement. I've seen our doctor do this, where they will provide a little dosing cup for liquid measurement rather than use the one from the pharmacy. They'll give it to you and they'll draw a line and say, this is how much medicine, and they'll write on there 2 times a day, or they'll go morning and evening. And so the information is on the cup, and that makes it a little bit easier. Now, that won't work all the time, but it's one way to address the dosing and numbers and measurement thing, because if the person's not familiar with milliliters and different dosing levels and what they read on the prescription pad, and then if you get the prescription label, and then if you bother to look at the booklet that the lawyers say you got to have with the drug, it could tell you something that could really confuse you. And I'm guessing most people don't read that information. We're just killing trees.
Or sometimes when they do read it, they don't understand it, and then they stop taking the medicine because they're afraid they're going to get something terrible from it.
Yeah,
something that only 1% of people who take medicine have it, but they because it happens.
Yeah, and that's just the worst thing that can happen, is if they get confused, they don't take their medicine, they stop taking the medicine, it causes a problem, and they don't know who to call, and they wind up back in the ER. So yeah, it's just all connected. Somehow we have to continue the charge on this.
Yep, that's the cost of self-literacy problem.
Yeah. Interesting topic today. I appreciate all your insight. We'll post links to the article that we use for our conversation. So why don't you tell folks where they can find you?
Well, I have a blog at www.notimetoteach.com, and I'm on Twitter at notimetoteach.
Okay, and you're also on other social networks, and all they have to do is just Google Fran London, and they'll find you in lots of different places. Now, I would encourage people to certainly visit your blog and read some of the articles there and comment, because I know you'll comment back and you'll communicate with them, and that's a good thing to do. Now, also know that you're going to be a speaker at the upcoming HCPC convention.
Right, ACEA, Healthcare Education Association.
Yeah, and
Meeting in Cincinnati in October.
okay.
And,
And for those of you that are listening, that we are recording this August the 5th, 2013, and so it'll be published sometime shortly thereafter that. So if you're watching this in 2015 or 2016 or 2030, assuming it's still up on YouTube, it's too late. You missed it. Well, Fran, thanks for that. Tell us the name of that app again. Was it
Simply Saying.
Simply Saying? Okay, and check that out in iTunes and the Google Play Store, primarily for residents, you said, right?
Yes.
Okay, great. For those out there that are in the hospital environment that are interested in adding video, you can learn more about using video on demand at our website, synergybroadcast.com, and look for our video on demand application called MMDS, or Medical Media Delivery System. And I also want to point out, I mentioned it early in the show, but Fran's book is available wherever books are sold in regular paperback and ebook form. And for those that might be interested in group purchases, her publisher, Pritchett and Hull, their website is p-h.com. They offer a sizable discount for bulk purchases that you can use for groups and in-services, and I would encourage you to do that. So, Fran, thanks very much for your time and your input today. It was a great topic, and I look forward to speaking with you next time.
Okay, bye, Chuck.
Bye-bye.